Next, a hearing on Gulf War illnesses. Two House Veterans Affairs subcommittees heard about the possible health effects of the drug known as PB on Gulf War veterans. Officials from the RAND Center for Military Health Policy, the Defense Department, and veterans groups testified at this hearing, which lasts over 3 hours.
Getting busy?
Here we go. I'd like to turn the podium over now to Dr. Ghulam, who will speak about her research.
Mr. Chairman and members of the subcommittees, as the committee knows, pyridostigmine bromide, or PB, was a drug taken during the Gulf War by an estimated 250,000 U.S. troops as a pretreatment to protect against nerve agent attack. PB was approved by the FDA in 1955 for treatment of myasthenia gravis, an autoimmune disease that affects the muscles. During the Gulf War, it was designated an investigational new drug for pretreatment for nerve agent and was supplied to U.S. forces under an FDA waiver of informed consent. Technically, PB is a pretreatment adjunct, a drug that must be taken before exposure to be effective, but that confers benefit only if post-exposure treatments are given as well. RAND was asked to perform a literature review to evaluate whether PB could plausibly be related to increased health symptoms in Gulf War veterans. The literature review was used first to identify theories that might link PB to symptoms in ill Gulf War veterans, and then to assess the evidence pertaining to these theories. The issue of efficacy of PB as a pretreatment for nerve agent was also addressed, but will not be reviewed here due to time constraints. The identified theories fall roughly into two categories. One set of theories describe mechanisms by which PB may lead by which there may be heightened susceptibility to effects of PB in some circumstances, so that some individuals might experience effects, including possibly toxic effects, while others do not. The second set of theories describes ways that PB may actually lead to chronic symptoms. I will discuss these theories briefly. Regarding theories of possible heightened susceptibility to PB, one proposes possible individual differences in processing of PB. Indeed, our review found evidence of differences at many levels. Even supposing the same oral dose of PB, which was not uniformly taken, there are 7-fold differences in blood levels of PB in humans from one individual to another. Moreover, for the same blood level of PB, there are many-fold differences in the percent inhibition of an enzyme affected by PB and through which it exerts its action. Thus, depending how long after PB administration one looks, there may be up to 15 to 25-fold differences in enzyme inhibition for the same oral dose from one individual to another. Finally, for the same measured enzyme inhibition, there are substantial differences in clinical effects, including toxic effects of PB. These widespread differences in processing of PB from one individual to another could lead to substantial differences in susceptibility to effects of PB, including chronic effects, if any occur. The second theory notes that whereas ordinarily most PB is excluded from entering the brain by something termed the blood-brain barrier, which bars access of many substances, recent evidence from animal studies suggests quite a bit of PB may access the brain under some conditions, such as stress, heat, and chemical combinations, conditions to which some Gulf War veterans may have been exposed. This could increase the chance for brain effects of PB to occur. In addition, one study found that PB itself may enhance access to the brain of normally excluded substances, such as infectious viruses. A third theory notes that toxic effects of PB may be greatly enhanced, in some cases in a synergistic fashion, by concomitant exposure to other factors like pesticides and nerve agents to which some veterans may have been exposed. These three theories were all found to be viable. That is, they had enough supportive evidence that they could not be rejected. The other group of theories relate PB to development of actual chronic symptoms. Among theories in this category, literature allowed us to reject one theory, namely bromism from accumulation of the bromide in PB as a likely contributor to illnesses in Gulf War veterans. And the literature was inadequate to seriously evaluate another theory pertaining to multiple chemical sensitivity. The most important mechanism by which PB may lead to chronic illness suggests that PB may change regulation of a key nerve signaling chemical called acetylcholine. Acetylcholine is known to be vitally involved in regulating muscle action, pain, mood, memory, sleep, and skin function, domains that figure prominently in complaints of ill Gulf War veterans. PB acts by blocking the enzyme that normally breaks down excess acetylcholine. The consequence is increased unregulated action by this nerve signaling chemical. The body responds to this inappropriate increase in acetylcholine action by putting into place mechanisms to suppress the excess acetylcholine activity, so that signaling cells reduce production and release of acetylcholine, and receiving cells reduce the number of receptors to which acetylcholine can bind, and the affinity of those receptors for binding to acetylcholine. Moreover, there may be increased breakdown of this chemical. Since these mechanisms designed to suppress acetylcholine action occur in response to the excess acetylcholine action induced by PB, one might expect that they would go away as PB is withdrawn. But existing evidence from studies in animals suggests that the time courses of these effects differ widely from one another. Some are short-lived and unlikely to contribute to chronic effects in ill Gulf War veterans, but others are long-lasting or permanent, lasting in some instances as long after discontinuation of PB as anyone has looked. Could these chronic changes in regulation of acetylcholine action relate to chronic symptoms reported by Gulf War veterans? The answer is, we just don't know. Much more needs to be understood about the specifics of these changes and how they relate to clinical effects. However, again, we do know that acetylcholine is critical to the regulation of muscle action, pain, memory, and sleep, domains that are disrupted in ill Gulf War veterans. Thus, it is plausible that disruption of regulation of acetylcholine could produce symptoms of the kind that veterans report. The major conclusions of this study are: we cannot rule out pyridostigmine bromide as a possible contributor to increased health symptoms in some Gulf War veterans. More research is needed to clarify the role, if any, of PB in chronic health effects in ill Gulf War veterans. Some research of this kind is already being funded by the DoD, VA, and HHS. Finally, further research is needed to determine the effectiveness of the current dose of PB in protecting against SOMAN. The issue now is the complex one of trading off uncertain health risks, but risks now known to be biologically plausible, against uncertain gains from use of PB in the warfare setting. Thank you.
I thank the panel. I'll start with first sort of an overview. Dr. Golomb, what I hear you say is that in a synergistic way, environmental factors, the DNA, everything in this synergistic way in a fashion came to make some veterans more susceptible to neurological damage. Is that in a nutshell what you're saying?
I guess I would rephrase that to suggest that there is evidence of individual differences and effects from the environment, and we don't yet know whether those factors together with PB could be responsible for illness in some veterans. There is evidence suggesting that that's plausible, but the evidence has not yet closed the loop on whether that is a cause.
Dr. Cassells, do you agree with that, yes or no, what she said?
Basically, yes.
Okay. I think what concerns a lot of us, the Presidential Advisory Committee was given the responsibility to look at this, gave their first report in 1996, and yet we heard nothing from them. Now, the National Academy of Sciences has made a vague reference to this. As time goes on, many of us are frustrated, I think the members will point this out, because we're actually trying to come with conclusive evidence. Let me ask Dr. Golomb, your report appears to be a little guarded in conclusions, and I can understand that. In your personal view now, what is the likelihood that PB alone or in combination caused Gulf War syndrome?
I guess I really can't separate my personal view from my view as a scientist, and I would say...
Let me rephrase the question. Would you take PB yourself?
Clearly, from doing this report, I have reservations about the possible health effects.
All right, now we're getting to the understanding what you're saying. You've done the report.
Yes.
You were in Kuwait, Saudi Arabia, and they come to you and they say, you're going to have to take a PB pill yourself today, and you're going to have to continue to do this. So my question is, would you do it, knowing what's in the report?
What I would say is that the full force of considerations never falls on one in a hypothetical setting. And hypothetical answers are known to be poorly correlated with how people actually behave. There are many considerations that would be relevant, whether more evidence has come out regarding the efficacy of PB regarding SOMAN, what the known likelihood would be of SOMAN threat in that particular circumstance, whether additional research has been done into health effects of PB, et cetera. I would hope that before I would have to make that decision, more would be known.
And let me just say, in all deference to you, I don't mean to put you on the spot, but the issue is so serious, and many of us are trying to grapple with this, that I needed to get some kind of feel for how you felt.
I would clearly have reservations.
That's what I hear, and that's a fair answer, and I think you're safe with that answer, too. My last question is, Dr. Golomb, let's see if we can maybe bring this down to an understanding here. Gulf War veterans have indicated a variety of problems, from neurological symptoms to gastrointestinal problems to joint pains. Would PB alone or in combination be an explanation, a possible explanation for any of those symptoms?
It would be a possible explanation for all of those symptoms because all of those domains are influenced by this particular nerve signaling chemical acetylcholine that this review suggests, evidence suggests might have changed or altered regulation as a result of taking PB in some circumstances.
All right, my time has expired. The ranking member, Mr. Gutierrez.
Thank you. Well, it's certainly interesting that we have a panel of scientists and experts who are so cautious here this afternoon, and I apologize if anybody takes offense to that. But I think that we need to get some answers, and everybody's being so careful and so guarded and so cautious. And I would hope that we could move forward with this, obviously to get the right answers, but at the same time, to use our best judgment so that we can get some answers and be a little clearer on this. And to that point, I think it would be useful to have further explained Rand's role in the production of these series of documents, because it's almost like very legalistic. We wrote it, Rand's not responsible, it's our personal opinion. I don't know how I've heard that before. It doesn't sound like a scientist, it sounds like a lawyer trying to get from under his responsibility for his client. Having said that, is it customary for Rand to publish a report done under its review and not stand by its finding? You state that the opinions and conclusions are those of only the authors.
That's kind of a standard phrase that's in all Rand testimony. We do stand by the report, you know, we feel that the research was well done, well conducted, peer reviewed, and we believe that to the best of our ability, best of Rand's ability, we've ensured a high quality product.
You have obviously done a great deal of work in reviewing the literature on PB exposure and interviewing those who have expertise in this area. This is for Dr. Golomb. We clearly understand that we could research possible human outcomes to PB exposure indefinitely, ad infinitum. But I'm going to ask you to help us, non-scientists, lay people here, determine how seriously we need to take PB. Will you rate on a scale of 1 to 10, 1 being the least certain and 10 being the most, the certainty you have that at least some of the chronic illnesses Persian Gulf veterans are confronting today are due to their use of PB?
I would probably give it a 5 to 6.
You stated that chronic effects and chronic illnesses. So you're stating from 5 to 6 that the chronic effects and chronic illnesses that Gulf War veterans who took PB could be related to PB.
There is some evidence consistent with that possibility, but there are limitations in that evidence that prevent us from making that statement conclusively.
Okay. And PB is taken for what?
For what medical conditions?
For what medical condition?
The principal medical condition that it's taken for is an autoimmune condition termed myasthenia gravis, in which there is damage to the receptors for this nerve signaling chemical acetylcholine so that there is low acetylcholine action in the muscles. Administration of PB raises acetylcholine action in those individuals toward normal. In those who don't have this condition, rather than normalizing acetylcholine action, PB raises acetylcholine action to abnormal high levels. So effects in individuals with myasthenia gravis can't clearly be extrapolated. Another reason why extrapolation is problematic is that individuals with myasthenia gravis take PB lifelong. The leading theory in the literature review about how PB might lead to chronic symptoms suggests that it's not PB's causing high acetylcholine that leads to the chronic symptoms, but the body's response to that to suppress acetylcholine action by a variety of mechanisms that leads to problems. That would not show up while PB continued to be given, or it may not show up.
And you take this, and so given what we understand that Gulf War veterans confronted, was it necessary for them to take PB?
I'm really not in a position to address anything but the medical issues that involves military elements as well.
So you did a study, the military administered, as you stated, with a FDA waiver.
Yes.
So that there was no consent to the 250,000 people. Otherwise, without the waiver, you just can't administer this because there isn't enough scientific.
Sir, if I might state,
Sure.
I mean, it's we were not asked, and nor did we look into the policy implications of taking PB. The way the report has come out.
That's not my question, Dr.
Okay.
Anthony, and forgive me, but that thing turns yellow real quickly. You see, it just did. And then it turns red even quicker. The question is, and if you don't have the answer, we'll ask the people from DOD, is you give this drug to avoid something,
That's
to
correct.
avoid an illness, which you've described to us, and to avoid these effects. But you need to you need to actually have exposure to it. I mean, I don't take a shot for malaria. My doctor, if I tell him I'm going to LA or maybe New York, he doesn't give me a shot for malaria. He doesn't. If I'm not doing construction work and I tell him I don't intend on, putting a nail through my foot, I don't. I mean, there are. Did they need to give this in your professional opinion? Did they even need to give this drug, or did somebody just decide, just in case they might come along, this might come along the way? And did it come along the way, something that they needed to even give the drug for?
I think you need to ask DOD that question, but the drug is primarily given as a pretreatment for SOMAN, which implies that there was some risk of it being on the battlefield.
Was there any SOMAN on the battlefield?
I'm not aware of any, but I'm not also, I don't have.
That's fine. I don't want to take
just
up
let
the
me
rest,
finish.
and we'll ask the people from the, Dr.
I just wanted to say that we didn't have access to any of the classified information, so we're not really in a good position to answer your question.
And just, Mr. Chairman, I just think it's important that, if the military is giving 250,000 people something that turns out to be non-existent, we have some serious policy considerations here about what kind of medicines we're giving our military that are out there, and then maybe they never even were going to confront it. Anyways, thank you very, very much for your testimony.
I thank my colleague. He certainly can ask those questions to Dr. Sue Bailey, the Assistant Secretary of Defense for Health Affairs, who is on the next panel, too. Next, the Chairman of the Subcommittee on Oversight and Investigation, Mr. Everett.
Thank you, Mr. Chairman. I'm going to get a little less technical. I doubt if there's many members of the panel have understood, frankly, a great deal of what you've said. Does your study answer the question whether the Department of Defense should use PB in the future for the purpose of protecting our troops against attacks of the nerve agent SOMAN?
It does not answer that question. It does not address that question. It looks only at whether there could be a link between PB and chronic health effects.
Okay. But your own testimony a little earlier, you said that you would have reservations personally.
About taking an agent for which there may be chronic health effects.
About taking PB?
Yes.
No, thank you. Mr. Chairman, there are now over 100 different research projects on illnesses that could be related to military service in the Persian Gulf War. We've heard that there are 26 of these research projects looking into PB. Please provide the subcommittee, if you have the information, a list describing these projects. Also, please answer, how do we know these studies are asking the right questions? Who is coordinating the projects so that we won't be duplicating the gaps or making gaps in these studies? In other words, do we have 26 horses out there running in different directions?
Sir, and again, we're not the people to ask that question to, but I believe Dr. Fran Murphy, who is on the research coordinating committee, or was at one point before her recent promotion, can address those questions. The DOD's and VA's research, they have a complete list of, but we don't track that at RAND.
Let's say you did this report without any access to the other 26 projects going on?
We had access to lists of reports that were ongoing at the time the RAND report was being done. And I talked to people who were investigators in some of those reports, but naturally, the nature of what is being funded and so forth moves forward over time. I've seen a list of the studies that the DoD is currently funding related to pyridostigmine bromide, and those studies do fit into some of the gaps in the literature that we're currently looking at, but there are additional gaps that could profitably be filled by additional research.
What are they, please?
My personal scientific opinion would be that two domains that additional research could very well be profitable in would be to look specifically at the nature, time course, and possible clinical effects of changes in regulation of the nerve signaling chemical acetylcholine induced by PB and by other acetylcholinesterase inhibitors, which include pesticides and nerve agents. And the other thing that I think could help us pin down causes in illness in Gulf War veterans would be to look, as some people presently are doing, for objective markers of illness in ill Gulf War veterans, changes in blood flow regulation, et cetera, that would allow us then in animal studies to administer different possible causes like PB in combination with other things or low-level nerve agent or other possible causes, and look for those same objective markers in animals to help tie up what the most likely probable causes are.
Did you see any of these benchmarks in the research that you did?
There are some such benchmarks currently being explored by Robert Haley in Texas, who has some reports suggesting that there are abnormalities in what's called saccadic eye movement, when your eyes move from place to place very quickly. He found that one eye may move a little before another, not in a way that's discernible to the naked eye, but that would be one example. And also there appear to be changes in regulation of blood flow to certain parts of the brain, especially a part called the basal ganglia. That's not inconsistent with PB being a factor, because we know that when drugs of PB's class go to the brain, they localize in the basal ganglia. So things like that are lines of research that could help us pin down what the likely causal factor is.
Thank you very much. Thank you, Mr. Chairman.
Thank my colleague, gentleman from Indiana, Mr. Hill.
Thank you, Mr. Chairman. I think doctors, we're all frustrated with this. We spend all this money and we spend all this time and all this energy, and we're looking for a bit more clarity in all this, and we're not getting it. And I guess my question to you is do we need to continue to look at PB and spend more money on determining whether or not this can be a direct cause for Gulf War illnesses?
I'm not the policy person who makes monetary decisions, and I'm probably not privy to all the cost-benefit analyses of directing money here or there, but I do think that additional research in this domain would be profitable for us, understanding a lot of basic issues about how the nervous system work that would be helpful not only for Gulf War veterans, but for other illnesses, and also would be helpful for other possible exposures like organophosphates that have similar mechanisms of action to pyridostigmine bromide.
But I guess I'm asking you a question that maybe you can't answer, but do you think that if we do invest more money that we can get to a point where it does become clear?
I think there are many people who have significant reservations about that. I'm slightly more optimistic than many are that with the combination of attacks that I articulated to Mr. Everett, I believe it was, that we could get closer to an answer and possibly even have an answer for some or perhaps many Gulf War veterans.
Okay, well, let me switch gears then and ask another question. Is there any way to screen veterans to see if they are adequately producing and regulating nerve signaling chemicals? And if so, should we invest in screening sick veterans?
Currently, there are no good mechanisms for looking at some of the changes, particularly if the changes are occurring in the brain. But it could be, again, with research looking for objective markers of illness, and if that were found to be related to giving PB in animals, that those markers could be used as screens.
So we should invest in screening sick veterans.
It would potentially be helpful to looking for markers and specific elements of acetylcholine dysfunction that might then be screened for in Gulf War veterans.
So we should invest.
Again, this is, an area of...
I'm not talking about you making decisions about how much money Congress should spend. I'm not asking that. I'm asking for your recommendation.
I would recommend such investment.
Okay. Thank you, Mr. Chairman.
Thank you, gentlemen. Dr. Schneider.
Thank you, Mr. Chairman. Are we pronouncing your last name right? Dr.
Ghulam.
Ghulam. Well, I appreciate the work that you've done, and obviously has gotten a lot of people thinking, which I think is what these kinds of papers are intended to do and what RAND has intended to do through the years. I wanted to ask you, when did you first start work on this study?
I think we looked at the time course earlier today, and July 1997.
July of 97, so it's been 2.5 years, or almost 2.5 years that you've been working. The comment was made earlier today that you all are being too careful, too cautious, and too guarded. I hope that everybody that works on this stuff will be as careful and as cautious and as guarded as the science takes you. I think we've had too many mistakes made in the past in all kinds of diseases where we tend to overreact. Perhaps not the scientists do, but some policymakers do, and we need to look before we leap. I want to ask a specific question. I was impressed with the difference in the striking difference in blood levels between people taking the same doses. You've got 7-fold difference in blood levels and a 15 to 25 difference, I guess, in efficacy, or for want of a better word, on how it affects acetylcholinesterase. Are there other drugs, common drugs that have that kind of variation in blood level and effect based on the same dose?
I actually don't know the answer to that because I haven't been specifically investigating a variety of other drugs. It wouldn't surprise me if there were. There may be drugs that have a better toxic to therapeutic ratio, that is to say a wider range before there are significant adverse effects. I simply don't know the answer to that.
It just seemed pretty striking to think that if Mr. Hill and I were taking the same dose of this drug, that the effect could be 25 times greater in me than in him in terms of how it affected that enzyme, enzyme. That seems very striking.
Yeah, to clarify that, it depends on how long after PB is given as to whether you get that big of differences. But certainly there are a good 10-fold differences, and we don't really know if altered regulation is occurring, whether that becomes a problem because you've had high levels of inhibition 2 hours later or 3 hours later. Certainly at 2 hours, you can get differences between 50% inhibition in one individual and 0% in another.
Were there, in the written materials that we had from you, you talked about the problems of studies having been done on people with myasthenia gravis, and then looking at those effects and comparing it to normals. Have there been studies done in the past on pyridostigmine bromide on normals that do not have myasthenia gravis?
The military in both the U.S. and Britain have conducted such studies. Typically, they've looked to see what degree of enzyme inhibition individuals have before enrolling them, and they have excluded those that had particularly high levels of enzyme inhibition. Unfortunately, it wasn't possible in the Gulf War setting to individually monitor that, and so we really don't have a lot of good information on how individuals who have particularly high rates of acetylcholinesterase inhibition would fare. And also, those military studies uniformly did not look at long-term health effects and did not monitor for the kinds of health effects that are being experienced by Gulf War veterans.
So if I got what you're saying that when the studies on normals were done, people were excluded based on the drug effects on them, and it may turn out that those same types of people were the ones that had potentially could have had the effects that we now call Gulf War illness.
That's correct, but it's also the case that because nobody looked at the individuals even with more normal or usual percent inhibition, we didn't look at what happened to those people long term. We can't either exclude the possibility that there were health effects in those. We simply don't know whether either group would have chronic health effects.
You use the phrase long term. What does that mean to you?
Well, what it really means to me is long-term, like the kind we're seeing in Gulf War veterans. It means different things in different contexts. In animal studies, I think the longest in a rat study that anyone looked after stopping PB was 60 days, and there were effects still present. Now, many people would, there are rules of thumb in animal research saying that a week in a rat is like a year, but that's not really fair to say because it's different for every function one looks at. So we don't really know how that would correlate to long-term in humans.
I felt like a rat before and it seemed to go on forever. Let's see. The last thing I wanted to say was I happened to be, I think, laying in bed that night. I saw the CNN News the day that your report was studied. And I was really struck by the press reports of your study. I mean, some of you probably saw them too, some very dramatic statements being made about what your conclusions were. And yet, I think your conclusions are very appropriate. You talk about, I think your words are exactly, a possible contributor that risks are biologically plausible and that further research is needed. I mean, I think you're very clearly sending a message to us and to veterans that there's a whole lot of work needs to be done, and this is just one baby step on this, an important step. And history may show that it's a very important step, but I think it's very easy to overreact to one medical study, preliminary literature review of one of these possible contributors. But thank you for your good work.
Thank you, gentlemen. The gentlewoman from Idaho, Ms. Chenoweth, is recognized.
Thank you, Mr. Chairman. Dr. Golab, I'm very impressed with your testimony and the work that you have done.
Thank you.
I want to thank you for bringing it to the committee. Now, based on your testimony and the answers to the questions of the other members, I think that what I understand is that in the case of myasthenia gravis, that acetylcholine is used as a suppressing agent, right? Or the acetylcholine?
It's a little bit the other way. In myasthenia gravis, action of this nerve signaling chemical is abnormally low. What PB does is it abnormally raises that in other people, but it raises it toward normal. It normalizes it upward in those with myasthenia gravis.
Okay. So based on the reaction of MG patients, it was supposed then that in the case of preventing a reaction to nerve gas, that it would act substantially the same way. Is that what you're telling us? Because in your testimony, it indicates that this was designated an investigational new drug.
For the purpose of nerve agent pretreatment. And you're right, the presumption was that because it had long been given in this specialized population, and also I might add that it's also given for some post-anesthesia applications where neuromuscular blockers have been given. That's another setting where because of the neuromuscular blockers, acetylcholine action is low and giving PB brings it toward normal. The presumption was because of long-term use in these conditions, and particularly myasthenia gravis, at higher doses lifelong, that shorter term, lower dose use in normals would not be a problem.
But of course, your testimony indicates that the variables in different blood levels and body chemicals and chemistry there was not substantial time to really understand those variables.
And I would add that that had been known even from individuals with myasthenia. Individuals who appeared to have the same degree of illness were known to need widely varying doses of pyridostigmine.
So, Mr. Chairman, I think that what we're hearing is that this drug was given as an investigational new drug, and I'm shocked. I don't think we need to be investigating new drugs in the course of an impending war, giving 250,000 men and women an investigational new drug. Now, I know the FDA is cumbersome and bothersome, but this is very disturbing to me. And I have seldom heard in my career in Congress a more articulate and astute or brighter person in medicine or any witness. I am stunned by this, and partially because I have been involved with veterans who have Gulf War syndrome, and I have noticed something else that you indicated in your testimony, and that was there is literature that indicates that PB itself may enhance access to the brain of normally excluded substances such as infectious viruses. So that in and of itself causes the long-term effect, while the effect of the drug itself may be short-term, as Dr. Cassell's testified. The long-term effect of the suppression that you testified, and you may be not able to testify directly because you indicated you read it in literature, but I think that's significant. And I hope that in your future studies that you can enlighten us more on that, because that may be why we're getting some of the contradictions of short-term versus long-term.
Thank you. I would like to comment in defense of the FDA that they were sufficiently persuaded by the data in myasthenia gravis that their concerns in referring to it as an investigational new drug were actually not safety concerns, but concerns regarding efficacy. The issues regarding safety were really ones that were brought up later. So at the time, they did not perceive safety to be a major issue.
It was still under restricted use, wasn't it? And
it was FDA approved for those selected conditions in which it had been shown to be effective.
And that's myasthenia
gravis and the post-neuromuscular blockade conditions. But it's difficult, of course, to do effectiveness studies in humans, and at the time, their major concerns revolved around that.
So the suppression of the effects of the Soman had not been studied on humans, just on animals, or?
Well,
it was a huge study in Gulf War.
Soman are generally benefits against lethality, against death, and the literature suggests that there's no evidence to suggest that there are benefits against sublethal effects, that the incapacitating effects would still occur. So performing effects to see at what level of Soman there's lethality in humans would clearly be a problem.
I see. Thank you very much.
Thank the gentleman for questions. The gentleman from Indiana, Mr. Boyer, who was actually was in the Gulf War and has experience taking PB.
Well, Mr. Chairman, I think you name it, I think I took it or was there in it. I've had the anthrax shots. I took the PB pills. We burnt the diesel and JP5 in our heaters and tents. They fogged us with DEET. They gave us all the multiple immunizations. Was even in 2 days of the fallout, based on Bernie Rosker's studies, of the chemical fallout from the Camisea. So I got to spend a couple nice days in that. Yeah, I think I've been dipped. Let me. There are a couple of things, though, I do want to make these comments. And I'd also like to respond to my colleague from Indiana, Mr. Hill, because he asked a very good question. It would be easy for us to do a little Monday morning quarterbacking years later, but I can tell you at the time, I don't want to speak for all 200,000 of us that were actually on the desert floor. We had been very well briefed. DOD did a very good job briefing us on Iraq and Iraq's use of chemical munitions, what they had done against Iran in the Iran-Iraq war. Many of us we were very prepared, not only for biological but chemical, also prepared for tactical nukes to be used in response, that if in fact chemical munitions or biological compounds were used against us. So we were very prepared on the ground, and we anticipated that it would actually happen. And it was probably the most frightening thing as a soldier. If there's a bullet out there with your name on it, you accept it as your fate, but don't gas me. And so it was our greatest fear, and we took it very seriously. So when you say, well, how can you actually give such a drug to soldiers? We took it willingly. We wanted to take it. You give me that choice again versus sarin gas in the next room or taking these pills, I'm going to take them because I know what's going to happen if I go in there with nothing. So we took those choices. Fortunately, I guess when the first Scuds came in, they were non-chemical. They were conventional munitions. And after about 5 or 6 days, I stopped taking the pills. I don't know what others did, but that's what makes it so difficult for science. They don't have a specific, detailed environmental assessment that they can do to study exact numbers and what were they given. And ma'am, you talked about the individual differences. What an understatement. Just given human physiology in and of itself, let alone all the numerous combinations and factors that you can do. So when Mr. Hill, when you ask a study, and I can understand the strain on patients because I'm with you, but it is very difficult for us to come to something concrete. And I cringe every time I hear somebody use the word Gulf War syndrome. I just want to jump out the window. There's no such thing as Gulf War syndrome. It's Gulf War illnesses. It's multifaceted. It's what challenges us to try to find the causal link. Will we ever find it? Maybe not. Why? Because it's so multifaceted and there are so many individual differences, not only even by gender. But it should not. We should not stop. I guess that would be my advice to my colleague. We can't rest on this one. And I want to compliment Bernie Rosker for having Rand Report do this. You, sir, are a tremendous compliment to the building across the river because you have done more than any other man or woman that I know of on behalf of Gulf War veterans. You've taken a lot of heat, Bernie, but you're doing the right thing. And I guess I don't want to get into the questions. I just wanted to make this comment. I want to compliment you on your study. And if you're looking for advocates for further research, you've got one. I yield back my time.
I thank the gentleman for a very compelling statement. I think we're going to do another short round of second questions, maybe a clarification. My colleagues have indicated they want to do this, so if you'll be patient with us. I just have a clarification, if you don't mind. When my colleague, Mr. Gutierrez, asked you to rate from 0 to 10 the factors, you said 5 or 6. Would that qualify as a maybe? That maybe?
It's a definite maybe.
Definite maybe.
Right.
Okay, so a 6 is a definite maybe. 7 is a...
You know, I really hate to even answer these kinds of questions.
I understand.
Along a continuum where there's so much residual uncertainty.
Well, you sound very knowledgeable and erudite. Are there other risk factors that you would rate higher than a 5 or 6 from your knowledge?
Based on my knowledge, which remember I was designated to do the report on PD, so I don't necessarily have the same degree of knowledge about other risk factors. But I would comment that, for example, in an epidemiological study published by the British this year, where they looked at a number of different exposures and their relationship in British Gulf War veterans to CDC-defined Gulf War syndrome, the risk factor that appeared to have the strongest relationship was PB. However, other risk factors also had significant relationships to development of Gulf War illness. So I could not say that there's another factor that I would perceive as stronger, although one could argue that all acetylcholinesterase inhibitors, which includes not only PB, but nerve agents and organophosphate and carbamate pesticides, share similar mechanisms of action and could all be linked to similar kinds of health effects.
Okay, definite maybe. Let me ask you this, see if I understood this. When this is following up the gentlewoman from Idaho, So the FDA approved this drug with the understanding that it would be granted a waiver because, as Mr. Boyer indicated, the dire circumstances, that it was better than nothing, so to speak. Would you characterize, I mean, Mr. Boyer said he would take it, knowing what the alternative was. But looking at this from an experimental scientific outlook, and since the military didn't know, as I understand, definitely that this would do the job, would you say this was an experiment on our military? She characterized it that they were experimenting with our military with this drug?
I certainly don't think that was their perception, because the FDA had not had concerns about safety. So if the residual concerns were about just how effective is it, then they could not have perceived themselves as doing anything except giving what they thought was the only potentially effective countermeasure. Now, there are issues that have arisen since then, both regarding safety and effectiveness, that might change the balance a little bit. But I certainly, from my understanding of what happened, would not characterize what anyone did as intentional experimentation.
Well, I mean, back then, but looking about it from today, looking from today back, would you characterize it as they were experimenting?
I wouldn't even want to answer that kind of question. First of all, I think it's a little bit of a semantic question. And,
yeah, I understand.
And second of all, sort of second-guessing people who are making the best decision on the basis of available evidence.
Let me ask you, the other countries that were involved, what other countries use PB?
The British, the Canadians. I talked to someone who did work in Denmark, and they indicated that the Danes used it. Dr. Rosker has talked to individuals in France, and his information is that they were given PB but never given the order to take it. Some individuals there may have taken it, but primarily what we know is the U.S., the British, and the Canadians.
Okay, and their studies are not as conclusive or is not a definite maybe as yours?
Well, the epidemiological study that emerged was from the British, and that is really the best epidemiology that's been published, and that did suggest that PB was the most strongly linked among possible exposures to illness in Gulf War veterans. That was based on self-report of use of PB, which has its own problems, and it certainly is the case that the British and Canadians are reporting health symptoms in their Gulf War veterans.
Did these other countries have to use the same approving authority that we did?
I simply don't know the answer to that. Mm-hmm. That's not part of what I looked at.
Mm-hmm. It is licensed.
Yes.
Oh, my understanding, actually, and Dr. Rosker can perhaps answer this better, but my understanding is that in Britain it's actually approved for
It's always been approved and licensed.
But I'd have to check on that to be certain.
Okay. And my colleague from Indiana says he believes that it's been licensed. Yeah. That's my list of questions. The ranking member, Mr. Gutierrez.
Thank you. Well, I want to thank Mr. Boyer for his comments about what soldiers are ready to do. And I think that's what all of the 250,000 people that took PB were ready to do. And that causes me a lot of consternation. And so when I raise the issues about people being careful and cautious and guarded, I mean, given the juxtaposition of Mr. Boyer's testimony that he would take it, and knowing what he knows today about PB, would take it again, because that's the kind of individual he is, I would hope that we would get some answers, because it seems that the panel sometimes doesn't want to venture here, doesn't want to venture there, and then we don't get to help the men and women that are out there. And so at the same time, I think that it is very, very important that, given what Mr. Boyer just said, that I would see the same, not from you, but from the panels that are going to come forward after you, the same kind of commitment, same kind of dedication, and the same kind of forcefulness in their commitment to serving our veterans who are clearly ill. And while this evidence is not conclusive, it's certainly leading us in a direction. And after 19 hearings, maybe we're finally starting to get to a point where we can say, as Mr. Boyer doesn't want to call it syndrome, I'm going to respect what Mr. Boyer says. I wasn't there. So these illnesses that our veterans have, it would certainly be good after 19 hearings, and I think your information is going to help us, so that this committee doesn't continue, because Mr. Boyer and I remember when we sat on this committee and people would come forward and tell us, well, you know, they might just be malingerers. You know, they might be making it up, and they might be looking for an out. They might be looking for a pension. And so it gets real frustrating sitting on this committee after 7 years of examining this. And everybody was all worked up when they came back from the Gulf War, and they said they were our best and our brightest and our most courageous. And we had parades and we had celebrations, all very fitting. And then after the parades and the suites were swept up and everybody went back to work in their regular line of work, making America better and stronger, everybody started questioning these people. So I think the information today, had we known it in '93, maybe would have gotten us quicker to getting and resolving the issues and getting treatment for these people. Because I think that if I walked into my doctor's office today and I had conditions that are being explained by Gulf War veterans, and he asked me a series of questions and he got to ask me that I take PB, he might say, well, I think maybe I know why you feel that way, other than saying, you know, Luis, maybe you're just tired, a little lazy, a little unconcentrated. Maybe you want to malinger. Maybe we need to send you to psychologists. Because really, physiologically, there's nothing wrong with you. I don't think, given your study, that anybody would say that somebody who feels some of the chronic illnesses that Gulf War veterans are going to say they need to see a psychologist. I think they're going to need to see a physician. So thank you very much.
Yeah, Dr. You have Dr. Snyder, second round of question.
Just one quick question. What was the normally prescribed milligram dose range of our Gulf War soldiers, and what's the normal range prescribed for patients with myasthenia gravis?
The dose range for our Gulf War veterans was 30 milligrams 3 times a day. And in general, for myasthenia, the dosage typically starts at 60 milligrams, perhaps 3 times a day, and goes up to potentially 10 times that, depending on the individual.
And so it would, I guess, well, I'll just make a statement. That was probably a factor then in the FDA's waiver when they were looking at the substantially lower dose.
That's exactly correct.
Right. Thank you. Thank you, Mr. Boyer, for your comments. Appreciate it. Dr. Snyder.
Right. Dr. Anthony is suggesting, okay, never mind.
All right, the gentlewoman from Idaho, second round, Mr. Boyer.
I just have one.
Sure.
I have one. I want to thank Mr. Gutierrez for his comments, and you're absolutely right. Remember this in the beginning, along with Joe Kennedy.
Yeah.
A lot of hard work with a lot of doubters at the beginning. But I still think we've got a long way to go. I really do. I also, when I think about soldiers, sailors, airmen, and Marines, when they're called to duty, they want whatever is the best at the moment in time. The best armor, the best munitions, the best body armor, the best, whatever it is you've got that's the best. And if what we had were these pills were the best at the time, that's what we'll take it. Because obviously you know what happens if you don't, and you get the nerve agent and the Scud that landed off on us. I'll let you know the first Scud that hit in Dhahran, it was televised back home as it landed in the desert. It didn't land in the desert. It landed in a John Deere implement dealership's lot that was right across the street from us. And the concussion was so loud, you could just shake your entire body. And were we scared? We were scared to death. Absolutely, we were scared. Were we glad we took the pills? You bet. In training, when they say, well, you have all your MOP gear on, and at the time, we believed it was chemical. And you'll understand real fear when you know and believe that what just hit across the road from you is chemical. You're scared to death. And you're in that chemical suit. I was in it for well over an hour. You think I wanted to take it off? No. I didn't want to take it off. I may have even doubled up nap pills. I don't know. One thing, though, I'm thinking about, when I went over to the United Kingdom and met with a lot of my comrades from the UK who were also suffering from Gulf War illnesses, they immediately pointed to the NAP pills. And with it being licensed over there, they have a great concern. Do they have some ongoing studies that you've been doing that would point to some form of causation with these pills? And are they concerned about it? Are they considering removing the licensure of the drug? Or where does the UK stand? Do you know?
I honestly don't know the answer to that. I've had contacts through Dr. Rosker with individuals in the U.S. who are doing research, but not.
All right. I'll ask Dr. Rosker, Dr. Bailey that question. The second question I would have, are you aware of Dr. Haley's work with multiple chemical sensitivity?
I'm aware of Dr. Haley's work. I don't think his work is primarily directed at multiple chemical sensitivity.
Well, it's DEET in combination with a lot of other things.
Okay.
And I can't help but think.
So chemical combinations.
Yes.
Yes, I'm aware of his work, and he's also, there are also many others who are doing work on chemical combinations and synergistic toxicity.
We would also be interested in your ideas about how you can mold a couple of these different projects together.
Right.
Okay.
Let me comment that looking at interactions among exposures is very difficult, because as the number of potential interactions goes up, the number of interactions goes up as 2 to the n. And I know that doesn't mean much to you right now, but as an example, if you have 10 possible things interacting, there's over 1,000 possible interactions that one would need to look at. And that's the reason, for example, why the FDA does not require, when licensing drugs, that they be evaluated in combination with other drugs. And toxic interactions generally only show up as a result of people in the real world using those agents in combination. There are strategies, and I propose one in my report, for trying to narrow down the number of studies that would need to be done to evaluate multiple exposures in combination, but it is a difficult problem because of the number of interactions, the rate that the number of interactions goes up with the number of agents.
Well, I guess we're not as moved, because we want you to define the difficulty. That's why we try to get science to be exact, even though it's very difficult.
Yes.
And that's why we're willing to fund it, to look at it, so we can understand it, so we don't run into these problems in the future. So if you've got some ideas, please share them with us. Not at this moment, but
okay.
please.
Well, they're in my report, and I would be happy to make them available as part of the record, or however you would like.
Thank you very much. I yield back.
I thank the gentleman. I think we've completed our first round of questioning for panel one. I want to thank you for your patience and the time that you gave us, and we'll look forward to continuing this discussion. If we can have now the second panel.